Welcome to Getting Wired, Decoding Neurointervention, the podcast that takes you inside the world of cutting-edge neurovascular care. Hosted by Dr. Rajeev Sivasankar, a highly experienced interventional neuroradiologist, this series is dedicated to unraveling the techniques, innovations, and real-world challenges of neurointervention. Each episode features in-depth discussions, expert insights, and case-based learning from some of the most experienced masters in the field. From advanced procedural techniques to the latest breakthroughs, this is the go-to resource for specialists looking to refine their skills and stay ahead in the ever-evolving landscape of neurovascular intervention. Get ready to learn, explore, and master the art of neurointervention. This is Getting Wired.
Hello, friends. In today's episode of Getting Wired, we're very happy and excited to have Dr. Fabian Arnberg Sandor, who is a dynamic interventional neuroradiologist and the head of his institute at the Karolinska University, Stockholm, Sweden. Hello, Fabian, and welcome.
Hello, Rajeev. Pleasure being here, and thank you so much for inviting me.
Great to have you. So, Fabian, today's episode, we will be dealing with something that we all do every day. And, friends, Fabian just told me before the show that there's 2 ongoing thrombectomies in the background as he's doing this podcast. So today's topic, coincidentally, is management of large vessel occlusions and mechanical thrombectomies. So we're going to get into the meat of the matter as to how Fabian selects his cases, how he chooses his hardware, how he gets to his peri-procedural work and post-op work, etc. But before we get there, Fabian, can you tell us a bit about your shop? What kind of institute you have? What is the infrastructure?
Yeah, sure. First of all, I really love this topic. Usually I do talks on arteriovenous shunts and whatnot, and more not so common situations and pathologies. But I am born and raised as a neurointerventionalist in the LVO area. I really started training and doing a lot of stuff after the trials in 2015. So for me, with a background in abdominal aneurysm reconstructions, going straight into thrombectomy and large vessel occlusion treatments, this is the foundation for my neurointerventional practice, and it's fantastic to be a part of this, as we do so much good things for the patients at the same time, and to be able to learn and understand the complete panorama of neurointervention from this standpoint. So in our service, I work at the Karolinska in Stockholm. So we serve 3-4 million people with thrombectomy. It's a metropolitan system where we collect we are the only hospital in this region doing thrombectomy. So we have a very strong triage system developed by the stroke neurologists, which is simple. If the patient is hemiplegic, they come straight to us. If not hemiplegic, but with stroke symptoms, they go to the nearest hospital. Meaning that we have a very effective system of collecting the patient. So, and by this, we have steadily increased to a current number of 500 thrombectomies per year. We have 3 biplane labs and 6 physicians able to do thrombectomy. So this, in parallel with the hemorrhagic service, is the current. This is the current setup, but the setup has been dynamic. It's a big difference for the system if you do 200 thrombectomies, 300, 400. Everything changes. So it's still a dynamic, ongoing process on how to set this up.
Yeah, true that. And there is so much to learn from institutes which have such high volume practices, which is what this podcast is all about. So tell me, how do you go around choosing your candidates in your hospital? You have an MR-based protocol or you have a CT-based protocol?
Yeah, so we have a CT-based protocol. We use the latest generation of a photon counting CT, which gives superb resolution in finding medium and distal vessel occlusions. Also, so what we do, we get, of course, a native CT, and then we do by history, we have a strong history of doing angiograms. So we do three-phase angiogram. First phase, including the heart, and the second two phases for the skull. Why is that? Okay, so if you do at least two phases or three, at least one of them will be good, and the first one allows a very good assessment of the craniocervical vessels and the roadmap to the skull, which is important in stroke. And we also are exploring how much gain we can get from also imaging the heart. I mean, we have some cases with large myxomas detected on the first scan, which can help you with your strategy later on. And then we do perfusion imaging. This is the workup for, but this is also a dynamic and has changed over time. I mean, previously we were driven by perfusion imaging and the percentages here and there, but realistically now, with all the large core trials, if you have an LVO, take it out. So I think we will probably change our protocol at some point. But what we're doing now is more changing what we're doing after. So now we are switching from dual energy CT as a routine at 24 hours to doing MR instead, to be able to better understand the situation after thrombectomy and after stroke to help the patient further on.
And what about, do you use lateral scoring, or does it in any way help your practice?
I mean, we used to do that, but with the large core trials, with all the data out there, I mean, what's the point? I mean, aspects.
Yeah, true.
What's the point? So for LVOs, which is the topic for today, take it out. So I would say,
which comes. Yeah. What I was getting to is that, if we have someone with a high NIHs, anything more than say 5 or 7 or whatever we want to keep as a cutoff, why not just do an NCCT and then take them to the lab?
Yes, and this is of course the case. So all the patients that we have from that does not come here immediately, that comes to another center because of maybe more minor symptoms. If we have an LVO, we have the NCCT, we don't push them for a perfusion or something else. They go straight to the lab.
That's right. And what about aspects? Do you have any limitation? Do you exclude anyone if it's a lower aspects, 0 to 2, 2 to 5?
No, not anymore. I mean, used to be the case, but I would say no, not anymore. But I mean, what is excluding now? It is, I would say, it's more, and our stroke neurologists do a very good job helping us out here to check whether the patient, I mean, dementia being placed in an elderly home and situations. If the patient is not independent, I mean, the point of this treatment is to make people keep their independency, right? And if that patient, regardless of age, regardless of anything, almost was independent before, thrombectomy will help them having a better chance becoming independent again. So I think I think the triage is more clinical today, making sure, and of course we have the electric documentations shared all over our region, so it's quite easy to see if there are any important contraindications. But I would say, yeah, finding out whether the patient is dependent or independent is the big thing now.
So just to clarify, which let's assume there's a patient who comes in with a wake-up stroke, right? And you see a territory which is about an aspects about 3, and you see a large hypodensity.
Yeah.
So would you like to go in for a perfusion diffusion mismatch as a inclusion, or would you like to go for a collateral scoring, or would you just push him? It doesn't matter.
I would say we're going more towards it doesn't matter, because is it an LVO and the procedure looks straightforward, go ahead, do it.
Do you think that there is an increase in ICHs, SICHs, if in the subset?
You mean if you reperfuse?
In low aspects, yeah,
I mean,
yeah, yeah.
this was indeed a big issue and the question before, but I think there was a lot of strong data coming out of our institution on this topic, and we could not find any signal that we were harming these patients. The question then became, are we doing anything good for these patients? Are we changing the trajectory in any way? And then the large core trials told us very clearly, if you're doing something, you're doing something good. So, okay, so this is where we are now.
That's good. That's very encouraging to hear from a high volume center like yours. So let's get back to the protocols that you use. So in all your patients, let's assume they're within a 4.5 window period. You go ahead with tenecteplase or TPA, or
Yeah.
you bridge, or you don't bridge in LVOs.
We do definitely bridged. Yeah, tenecteplase if no contraindication. Yes, and I know there are some conflicting evidence on this topic, but I think we have also seen strong signals that bridging does have a beneficial effect.
Agree. Right. And since we're talking LVOs here, I just want to understand from you, what is your, and you are also, for listeners who don't know about your institute, Fabian also runs a fantastic fellowship programs. So there are calls which are dealt with as fellows. So do you have a protocol where you have a standardized approach? So can you just talk us through that? What is your short sheet? What is your PGC? Do you use it or not? What is your structured device?
Yeah, so
choice?
I would say we are still. I mean, this has changed also a little bit over time, but currently I would say short sheet, balloon guide, and to start out with aspiration as a first general rule or general approach. But then again, of course, this you have to adjust. So if there is a large clot burden, okay, then probably add a long sheet. If you and maybe add stent retrievers, maybe add one stent retriever, maybe have two. And of course, we don't have the randomized prospective data to say whether you should add one stent retriever, two, or whatever. But for yourself as a operator, we do have, and this differs in the team, but I think the common denominator here, or how to say, is that we all have different approaches. We have different techniques, and I think this is maybe the way to go for everyone. Okay, so if you master one approach, this is good, of course, but I think the way is not exactly what you do, but that you have different kinds of tools, so you don't stand there and do the same thing all over and over again. Because I mean, this was the case back in 15, that you heard these stories. Oh, there was this guy somewhere that did 15 passes with a stent retriever and he got the clot out. I mean, this is not the way we do it today. I mean, if you don't get the clot out with your technique, okay, then you change something, you do something else, because apparently your technique did not work. So for myself, typically, if there's IM1, go with the aspiration catheter, and if it works, it works. You're done. But if it does not work, maybe try again. And if it does not work, you add tools to make have a different action on the clot.
True. So while I agree with that, can can you just talk us through the specifics? So you go in with say an 8 or 9 French short sheath, and you have say a walrus BGC is your choice, or you have a long sheath. I don't know what you use. So just talk us through what is your first step out there, because you have fellows all over the country and the world who will be wanting to know what does what do other institutes do.
Yeah. So I mean, we're happy to have. We have tried most of the material out there. The thing that we don't have access to yet in Europe is the super bore catheter. So this is not we have not explored yet. So we have aspirations catheter up to 0.74. It's a Vecta 74. We have the Red 72. It's the largest aspiration catheters. But for the balloon guides, we have tried and used them all. And I would say that the newer generation, the Bobby, the Walrus, the Embogard, I mean, they are. It's good material, but the Merci is still also good, and the Flowgate is good. So I would say what has happened there is that the newer generation are able to actually access the skull, and you're able to inflate the balloon guide within the skull and creating a better aspiration. And I have some videos, small clips, if we want to have a look at some of this stuff. I can show it, but still today I think we use the balloon guides, and to navigate them, I mean, they are super good material to navigate over a Berenstein or a SIM or a VTech catheter. So, but I think from the access point of view, it is important to get your balloon guide as high up as possible, and preferably into the petrosal segment.
True. And do you sometimes it's tough to get these aspirators across the ophthalmic, and it doesn't take that bend that easily. So
yes.
Do you have?
Yeah. And people do different things, and I can, if you want, I can show you some stuff on aspiration here, and
Sure.
if I just see if I can share my screen here. So you're able to see me on screen, right?
Yeah, absolutely. Yeah.
Yeah. So let's see on the aspiration part and what we're talking about. So this is what you want to do, right? You want to get your aspiration catheter up to the clot. So this is just an image showing that. And I would say this is the simple approach. And this is, I don't know what this is. This is a soft distal access catheter. It's just simply pushed this way. And you can see this is the segment you want to navigate, right? And I would say the more I do, the more I just push it. But you can steam shape your aspiration catheter, and you can use the wedge type of microcatheters to be able to do this transition. But for me, I would say using the Terumo wire, just gently passing, and it works in a lot of cases. But I would say what we learn now is that these catheters are so soft and atraumatic. So if you see here, this is in the media bifurcation, you can just push them around. So, but still, I mean, you have to find your way of doing this and what you are comfortable with. But there's so many different techniques, and but I would say do not underestimate. Just give a little bit more push, and your soft stack will just pop by.
In your experience, in your hands, do you have a system gradation that your choice by use? Like first, would it be a Red 72, or would it be a Vecta, or would it be say a React, or?
Yeah, I think it's this is a good question. So if you see the clot on the slide here, this is the question also for aspiration. People say, oh, there's a large clot, aspiration maybe is not good. And I would not say that because this is a huge clot. This is a super large clot. And I would say then I will try to, what makes me go, I would say all the aspiration catheters are good. The Sophia 6, the Red 662, the Red 72, they are all very good material. So it's in your hands, right? But for going, but I would say it's a very big difference of navigating a Red 62 and a Red 72 across the ophthalmic segment. The 62 is much more agile, will get to the M1, M2 very much easier, and is able to take out a lot of clot. So how I choose the 72 or a larger, it is, I'll show you on this slide, and it's all about how the siphon is, how tight is this angle. And for this case, it's a large clot. The angle looks good. So, and it's also about, do you have a straight carotid? Are you able to get with the balloon guide all the way to the skull base? So you have good push, and then you can just take your 72 and you just give it a good push like so. And then you're able to suck all this clot out. And if you're able to aspirate large clot, I would say it's about, is the clot a little bit softer, it comes out.
So to just summarize, so you use aspiration as your first line, and
Yes.
in your hands, you get a good first pass effect with an aspiration. If not, you gradually build it up to adding
Yes.
a stent retriever or two or whatever, or a
Yes.
combination.
Yeah, I
Right?
would say for the regular M1 clots, I would say for the one important thing is here, when you get with your aspiration catheter up to the clot in the M1, then you aspirate. You don't pull the catheter out. You just pull it back to the ICA terminus below the ICA T. If you still have a vacuum, if you still have a grip on the clot, okay, then you can wait a little bit and see if the clot comes shooting out, but wait for a couple of minutes. But if you get blood in return immediately, you know you did not get the clot, or it's in the So,
true.
but it's about what is the first pass here. This is a maneuver that takes you a couple of minutes to do. So so it's a test. So you already know if you got the clot or not. But of course, I see some people taking the whole system out, and then of course, it will take time. But you have access. You know if you got the clot on aspiration or not. If you did not, well, you increase your efforts.
And does it matter to you? Like sometimes, if you see a hyperdense MCS sign, it's a RBC-rich clot. So,
Yeah.
or that the patient is a chronic AF and or an infective endocarditis, he's going to have a slippery clot. Does it matter to you that you know what you're going to be encountering and your hardware choice depends on that?
I mean, we wanted this so much for the last 5 years to really understand and to be able to say. But I fear, and I've done a lot of clot studies, pathology studies on clots, and unfortunately, I have to say that there's no rule, there's no silver bullet. There's no. I think it's you have to do an empirical testing. Test, does aspiration work? Yes, no, because I mean, calcified clots, really hard clots. Okay, then I think maybe this one needs a double stent retriever, but at some point, pure aspiration did the job after 7 passes of other stuff. So I fear we don't have that answer. We don't have that crystal ball from CT or the patient history. That's at least my experience.
True. No, I agree with you, but there are times when we assume that it is RBC rich, and then it doesn't matter what we take because whether you use an SR or an aspirator, it's going to come out all the same. So see, there's a big difference in every country according to our logistic structures because there's economics in it. There is The way our systems are built in each country, they're different. So every choice is going to be mandated as by what system we work in. So, which is why your approach kind of is something similar to what is done, say, in many centers in India, because we don't have the luxury of opening multiple devices at once, because there's a huge cost effect to that. So
I think this is a very important topic, and I mean, in different points in time, we will all work in different systems with different possibilities and limitations. So I'm happy to work in a system without any limitations for material, and but this of course can quickly change, and this is a responsibility to have, and that responsibility to be in this system is to think and actually don't run around and do everything. So within this system, I still think it's very important to stress that over my years of practice, I have found out that the most effective way of thrombectomy, I think, is to try to do that aspiration immediately, because it is a super effective way. It is from the health economics, it's very sound, and so this is what I do, and I think should be done.
so let's assume that aspiration didn't work. So we move to a stent retriever.
Yes.
And so do you for an M1, many centers and operators are moving to a double SR first up.
Yes, so this is so I know what you're going to ask me, so I prepared some stuff here for you.
Sure.
Oh, I just wanted to show this thing, and this is on the topic of aspiration still, and this is a concept that maybe is interesting to know. This is so this phenomenon where you now this is a completely different scenario and situation, but it shows you this is a balloon guide inflated within a carotid stent, and by aspirating hard on this, you can see how the vessel collapses, right? And this will happen if you have aspirate. Also, in the distality, this is another. I have another example here. Here is I think it's a Sophia 6 deep in the Sylvian fissure, and you can see the contrast stagnating on the clot here. And by hard aspiration here, you can see how it's sucked inside. But this is because under fluoroscopy, we don't see what is happening in the vessels if we don't have any reference points. In this case, we have the carotid stents as the reference point, and this you can work with this or against this. And for instance, if you inflate your balloon guide and you aspirate hard on it, at the same point pulling something from above, you will you may block the way or block your exit of the thrombus, but also you collapse the vessel. And but this is just on the topic on how aspiration works. But moving into the next situation is I would call it the best of two worlds, and this is I still consider this a large vessel occlusion. Patients has a lot of symptoms, and in this case, I did something. I just gave a little bit of a contrast to see what's going on, and you can see here the clot here, right? And importantly here for people getting into this business is the placement of the stent retriever and the aspiration catheter. First off, when you see that your angiogram, you can see where the contrast ends, right? The interface, and this is where you think that the clot is. but the clot usually is a little bit further in, right? So if you see the contrast coming up to here, usually the clot is a little bit further in. So if you aspirate, go to the contrast interface and push your aspiration catheter just a little bit more. Yeah, right. That's your impression too, right?
Yeah, right.
And another thing to get into, you need to get inside to understand. And this is, so people say, oh, where's the tip of my catheter? Oh, it's here, or the micro catheter. The tip of the catheter is not here. It's the catheter is actually a little bit more. The markings are usually a little bit proximal. This can be important in small aneurysm treatments, but anyway, get your stent retriever deep of the clot. That's one thing, right? And when the next step is when you pull on it, your aspiration catheter will go forward and you will get to the clot. Now you're able to, and this is a situation now, because what happens is that the stent retriever, when you pull it, it has the shortest way to the clot through the vessels. The aspiration catheter takes not the shortest way. It goes like this on. So when you pull, the aspiration catheter will, of course, advance it. And if you don't control this and start pulling on your aspiration catheter now, it can push your clot off, right? So, and I think how to do this is just take your time, pull on the stent retriever, aspiration catheter goes to the clot. Next thing here is a detail, but it's important. Now you cut the slack of your aspiration catheter so it does not advance and more. And then but in this situation, what is right? Should you pull everything out, or should you pull just the stent retriever through here? I'm not sure. I think it depends on how good is your access. Do you have the BGC inside the head? Will you get back here really quickly? Maybe you can pull everything. Is it a resistance? Do you feel that you actually pinch the clot? Maybe pull everything. A lot of details here, but and there's only one way to learn and progress here is to discuss with your colleagues and do a lot of thrombectomy, and you will. And of course, yeah, this is a recap.
I think that was a fantastic point you made. That if you should you pull your whole system out in a combination, or should you leave your axis and get only the SR behind? That's a great point, and it depends on the stability of your axis. Are you able to get back in as quickly? So that's, I mean, your examples and illustrations were absolutely spot on. So that's great. Thanks. So suppose you have to switch. Let's assume you're doing the M1 and you have ENT to the divisions. Do you? How aggressive are you in chasing them?
So you mean if you have if you lose clot into the divisions, how aggressive I am?
In distally, M3, M4s.
Aha, okay. So more distal occlusions. I would say, I mean, okay, now we have the new trials that tells us that distal thrombectomy might be not beneficial for the patient, and the signals are that it might be harmful. And okay, this is a whole podcast, Rajeev, to talk about this. But I would say, if the patient has a lot of symptoms, because we have to keep in mind that the patients in these trials did not have a lot of symptoms. Okay, so they had NHSS of like 6 or 7 in mean and less. If the patient has is clear, if there's a big clinical impact and you're able to reach the clot, I think you should do it, but considering a couple of things. For the MCA territory, going beyond the sylvian fissure, going beyond the sylvian point, meaning you can make this first bend, okay, I show you in this image, into the sylvian fissure, but then you have the next one under the opercular roof. So we did this. I mean, this is something I've tried for many years now. pulling stent retrievers under the opercular roof, the risk of hemorrhage is too high. So, and there is no way to control this. And people were telling us that, oh, maybe if you move you can straighten your axis by getting the your intermediate catheter to the M2. But I can tell you, I've tried all variants, and it's completely unpredictable. The risk of giving the patient a subarachnoid hemorrhage is too high by pulling the stent retriever. We can do other things. I mean, if you have a hemiplegic patient, but now we're going into distal thrombectomy and more difficult, it's more difficult stuff. We have several techniques that we can do, like placing a stent retriever and without pulling it, you can resheath and you can give some antiplatelets, boluses, and you can do. So this is all experimental, and it's another podcast. But
I know, which is why I restricted this to LVOs. But because many times when there are situations when we are doing an LVO and we end up with an ENT, which is something we have to deal with. Personally, I have also seen that, especially when you have a full dose of tenecteplase on board, and up to the M2s is fine, but you may see after 5 minutes, the clot has migrated from your M2 to your M3 and even further down. Yes. So that happens too.
Yes. So I think for our part, at least, we don't do regular stent retriever or even more distal, but so we're moving into other ways of trying to resolve the clot.
Right. Yeah. So when do you choose to do a double SR first up?
Double stent retriever. Yeah, this is the next thing here. And two hands can grab more than one. This is the quote from René Chapeau. And indeed, I went to Essen in, when was it? It was just before the pandemic, and I learned this technique, and I saw them do it there. And this is a large clot, right?
This is huge.
It's huge. So how to do this? The two stent retrievers here. From the first one you could not see, but the clot is actually extending into both. So this is all systems aboard, and the clot is taken out in its entirety here. So, but the effectiveness of double stent retrievers is, I would say, it's undisputable. And René is completely right in this point that two stent retrievers are more effective than one. However, it's the cost of it is substantial, and I think. But if you are in an economic system that facilitates the use of double stent retrievers as a first approach, I think there is some data coming out supporting that the first pass effectivity of double stent retrievers may be beneficial for your population. But I think there are so many good ways of taking clots out, and you have to adapt to your system. And I would say in our system, even if we currently have the possibility of using what we want, still I think a double stent retriever setup could be a problem in the long run for us.
And what would what would be your choice? Is a 640 and a 440 as your two SRs?
So I put a 640 and a 440 just for the simple thing, because of course, even if you use double stent retrievers, you might have some clot still to get out. And if you have a 640 and a 440, you have both sizes. So if you have to go with one stent retriever, you have both. So
and what kind of catheter do you use along with it for a double SR?
Oh yeah, I think for the double SR, the material here can be I have, of course, prepared an answer to your question here too. So this is the steps for the double SR. Okay, you get your balloon guide high up. I don't know which one this is. Is the Bobby or the Walrus? I don't know. You place your first microcatheter, and you have to know your material. Some microcatheters are built more than others, and check the sizing, because if you're only using a balloon guide, you can fit whatever 21 catheters to double inside. But if you also want to do the maximalist with also a distal access catheter, you have to check the sizes of your 21 catheters. Some are bigger than others.
Right.
And in this case, so in this case, there's a large clot. There is first 21 in the M1. The second one is placed in the A1, and then you extend your stent retrievers. You place them here. Second step is to, and here I use distal access catheter 2. And the next step is to strip the microcatheters out, to pull them out, so you have better aspiration force in your access catheter here, and you make sure your balloon guide is entering the petrosal, and you inflate it here for complete flow arrest, and because the vessel here does not collapse as I showed you previously. So you will get this is the most, I would say, I don't know how to make a thrombectomy more effective than this one. There's two stent retrievers, one in the A1, one in the M1. There's also some aspiration force here. I don't know which one this is. Maybe it's the red 72, maybe. And then good result. But I think, I mean, you would be able to achieve this result with aspiration thrombectomy too. Just to make that clear.
Does it matter to you whether it's an open cell stent retriever or closed cell?
No, I've used
all these designs.
Yeah, I've used all the signs, and I mean, I had some really desperate situations where I also used the Nimbus stent retriever, which is one designed for with a dynamic segment for really tough clots. I'm not in the position to say that what the one stent retriever is better than the other. So I think it's important to have a couple that you are familiar with, so you are comfortable with how they look and how they behave. For instance, the EmboTrap has this little nose. So and this is good in some ways, but you can, of course, you have to make sure that you don't put them in a perforator. And I mean, the Trevo systems are a little bit tougher to push, so you have to be sure that you have a microcatheter that works well with your Trevos. And the Solitaires, I would say, is still the gold standard of stent retrievers. And but we have the Solitaire 3, which is a little bit stiffer than the Catch, and so. But I would say, again, we have a lot of good material. So it comes down to your experience and the operator skill, which I like.
True.
Yeah.
True. Right. Okay. So let's assume that, and we know that there's a very, very low rate of complications in mechanical thrombectomy. We know that a NNH is extremely, extremely low. So we don't really see too many complications. But do you have any tips or piece of advice as to how you would avoid any inadvertent wire perforations or inadvertent, other issues?
I think the overall tips here is to work in a environment that is good at picking up these things, because regardless how you do, from a technical point of view, you have to train a lot and to learn from people that are good, and and to learn basics of intracranial navigation. And for that, I would say, what are the safety tips? I think it's more of making sure that, so for example, in our shop, we have a system that records everything that goes on, all fluoroscopies, and which makes us, gives us the possibility to revise. And every time you have something happening that you don't understand, we go back and we look at it, and we learn from the images. And I can say this is invaluable. So many things I've learned from this, and also to have a strong culture in the team, that you're able to discuss mistakes and share this within the team in a good way. This is how you progress and learn. But for thrombectomy, how to avoid, I think when you start, and if you work with people that have worked a lot, like with experience, you can see how they move very fast with your with the wire, and this is something that I have seen with the fellows. Okay, now I have two important points to make here, and for the younger colleague, don't rush the case. Okay, that's one thing. Okay, time is brain and all that, but take your time. One important aspect is to look on the pre-thrombectomy imaging. Spend time. I see some people running into the lab. They spend too little time seeing the CTA before. They go into the lab, have not spent time with the CTA, ends up into trouble completely unnecessary, because you would have been able to anticipate a lot from the CTA, paying attention to it. So pay attention to pre-thrombectomy imaging, and I cannot stress this enough. The second point is, don't rush the case. This is not a race against time. In a way, it is. You have to don't lose time on stupid things, but don't rush the case, and you will be faster if you just take your time. Yeah, I think that's a couple of important points to drive home.
That's very important, and some other things which, of course, we have learned from people like Rene, are really overshape your microbias so that you can never ever get into those tiny branches, and you're in the right way because you're navigating blind.
Yes, this is a good technical detail to do. You can put a hook on your wire, and also you can the microcatheter itself navigating a 21 catheter in the M1. It will not do anything stupid if you just make sure that the wire is not tip to tip with your microcatheter. You just take the microwire a bit back. This is what I often do, and I just let the microcatheter find. And but again, you have to be a little bit I know the older types of microcatheters can be a little bit stiffer, like the Prowler catheters can be a bit stiff, but it's the ones that I use now. The Headway 21 is a super good catheter. It's very soft, automatic.
Gold standard, true.
Yeah.
And the other thing I like to do is always keep it pointing down south, so you never will have the perforators at risk. So when you're going blind at the MR.
Yeah.
Okay. So what about these tough situations like tandem lesions? You have a carotid which is gone. You have nothing up from the neck. And do you deal with it? How do you deal with it? You do a small plasty, do distal first, then come proximal.
Yeah.
Your thoughts on acute stenting?
Yeah, I think most definitely you solve the problem intracranially first, because that's where and I mean, two things, because if you I know people have different opinions on this, but I have a quite strong opinion, and there are cases where I have done proximal to distal. In the cases if you're not able to get access and some special situations, but I would say in the vast majority of cases, the primary objective is to recanalize intracranially, because the patient has oftentimes very good collaterals and has a complete sufficient circulations once you have done that. And then I think it's very good to take one step back and start thinking about all the panoramas of the stenting, right? Because this is not sometimes an easy decision to make. And I don't know how much time we have, but I have, of course, another thing. There is some things on the posterior circulation and double stent retrievers, but this is a case with a tandem lesion, and on the point of reviewing the imaging before. So this is a patient with both M2s are proximally occluded. There is a quite large aneurysm there, and there's also a critical carotid stenosis. And on the safety, and so this has been zoomed in, and so how to go about this? Rajeev, have you seen these? Sometimes you found aneurysm on your way.
So I will share with you a story where it came with an aneurysm which is not seen. It was an M1 occlusion.
Yeah.
And the moment I pulled the clot out,
Yeah.
I had a dissecting aneurysm in front of me.
Yes.
And I was not sure whether to leave it or to make another pass or what was to be done. It was very scary indeed.
Yeah, it is. And if you think about how the incidence and frequency of aneurysms and the frequency of thrombectomy, we should run into these situations more and more often. And we do.
Yeah.
And now we have, I would say, quite a lot of experience of encountering aneurysm during thrombectomy. But this case is a little bit special because when the patient on the aneurysm, before the aneurysm was thrombosed, on the pre-thrombectomy scan, and it was not picked up, and the patient got in the outside institution got tenecteplase, and on the table the aneurysm was fully recanalized from RTPA. Okay, so but
scary.
Yes, but so what is the direction here? I would say that the patient will die from. I mean, what is the worst thing to have? And the worst thing to have is to have a completely occluded, I mean, no perfusion to your hemisphere. This is the left side. This is both M2s are occluded. I mean, the outcome of this is devastating. So here is stent retriever, I believe, opening the first M2, the second, and then I did place a web here. And finally, also the question was how to do this. Okay, so this is also recanalized at the very end. So what I'm saying here is different points. One point is what we were discussing is what should you do first. I mean, recanalize intracranially. This patient has three problems: critical carotid stenosis, which was when looking back symptomatic, has a media bifurcation aneurysm, and two occluded M2s. So what is the biggest problem is, of course, the intracranial occlusions. The patient will do very poorly if this is not recanalized. So this is priority. Doing thrombectomy in the presence of aneurysms, we have done that a lot, and I would say the problem with aneurysm is the situation you describe when they are thrombosed and you expose them by thrombectomy and you don't know they are there, that you might perforate. And we have had situations with aspiration into a stump that was perceived as a vessel stump, but it was an aneurysm and with a bleeding afterwards. But for this case, you have to what is priority? Priority number one is to recanalize, and we can do. And I have personally never experienced an aneurysm rupture from a cold aneurysm from thrombectomy, even very close by. So just make sure not to navigate. And should you treat the aneurysm, that's the next. Maybe I think you could, if they are exposed, I leave them. But in this case was special because it recanalized and on RTPA. And I also knew that I had probably to stent this, exposing this recanalized aneurysm to another type of perfusion. So, but I think the important point is cold aneurysms encountered during thrombectomy, don't treat them, take the clot out, deal with them later. So, but don't be afraid to recanalize the vessel because of an aneurysm.
That was a special situation where you had an aneurysm too, but the classic tandems where you have only the distal M1 or the the M1 M2 clots or the T clots, and you have a very tight stenosis or an occlusion of the ICA.
Yeah.
And
Yeah,
acute stenting. What are your thoughts on acute stenting? Do you do an angioplasty, and would you like to come back in a couple of days and stent, or do you like to do it prima facie?
Yeah, I think this is now we're coming into some. This is not easy, I would say, and it's complex decision making, and you have factors like do the patient is the patient compatible with double antiplatelets because is there already a large infarct? Does is the patient really needing this carotid artery is one big thing, and I would say one extreme is a young patient with a dominant carotid artery that is dissected into an occlusion. I mean, you have to open that vessel. That's one thing, but a chronic over time, slowly progression of a stenosis with a small acute thrombus on top of it, dislodging, placing a stent here and double antiplatelets. If the patient already has an infarct, the patient can have a hemorrhagic transformation, and so I would say that one thing you have to decide is, does your patient need the carotid from a perfusion standpoint? And you can see this. You just look at the presence of ACOM, PCOM. Is this an old progressive lesion? Then maybe you should just do a PTA and play it more defensively. I think this. And you can choose to put the stent in at a later time point when you have more information, everything is stabilized, because having a bleed in an infarct from double antiplatelets, it's
Yeah, true.
no.
Yeah, which is why it's a little scary out here. I don't know how common it is, but ICAD is very common in South Asia and in India. So we see a large subset of acute ischemic strokes due to an underlying stenosis, either commonly at the V4 segment or the petrocavernous segments, and they're absolutely tight. In fact, we see the IC occlusions from the neck up because the petrocavernous is shut down completely.
Yeah.
So it's not the critical stenosis at the neck; it's the critical stenosis at the skull base, which is the problem.
Yeah. Yeah, we don't
that's
have
an
that
issue.
panorama. Of course, we see those patients, but I'm super interested. I know I learn a lot from you and the colleagues in your part of the world, and it's of great benefit for the patients here that do have that disease. But you are the experts in this panorama, and I mean, I think ICAD is still a very difficult situation because I'm not sure. We do treat them, but I believe our results are not as good as we want them to be. And I remember I asked you a lot when you met in Kazakhstan about how you manage these, and I think your comments on doing PTA and watch and see. This is something I started doing here, and I think it makes a lot of sense because yeah, placing a stent. But that's also another podcast. But I'm super happy to share knowledge with you guys, because you lead this, and happy to learn from you.
Thanks. But now it's so much of cross migration across the world. We have.
Yeah.
I was learning from Surprise that experienced operators like Nader and everyone are working in different parts of the world and seeing spectrum which earlier they weren't exposed to. So, and now a large part of immigrants are coming to your part of the world. So you're going to see diseases which are different all the time.
Yes, this is true, and I'm happy to say that Sweden is a welcoming country to immigration, and the immigrants doing a fantastic job in all the parts of the country, and especially at the Karolinska University Hospital. I think we have co-workers and colleagues from all over the world, but indeed we see this panorama, and we have to adapt and learn and share information so we can give our patients the best treatments.
And we are coming to the close of this session. So just a quick word on stroke. Many young operators, obviously it's very exciting to do the procedure, but there's a long, hard game after this, which is neuro rehab, monitoring the drugs, giving them the right advice. So how do you construct your department to do this?
So I think we have a group of very dedicated and skilled stroke neurologists that have made a really good workflow for the patients after thrombectomy. And before we saw Neurointervention saw all the thrombectomy patients at 6 months, 3 months. This is not possible anymore because of the workload, but I think it's important to when you start to see your patients. And to see a significant amount of patients after thrombectomy, because you will learn a couple of things. One thing you learn, that the thrombectomies that are good, you have done an amazing thing for this patient. It's a super effective treatment and so powerful, and this will encourage you in your efforts working with INR, which has some dark sides too, right? The second thing you will learn is that you will understand that some patients do not benefit, and the situation after thrombectomy may be, and I think we learned that, in the elderly population, that there is a big heterogeneity, that people do unwell after thrombectomy. Maybe you did a great work in recanalizing the patient, but the immobilization and the situation afterwards can affect the patient to a negative outcome. So what I would say is to build a strong team around thrombectomy, which means that you have a systematic approach by stroke neurology and a team effort all the way, because getting the patient from a M1 occlusion, finding them on the street, and then discharging them from rehab 2 months down, it's a team effort. And you taking out the clot with an aspiration in 20 minutes, that's a very small but important part of it. So, but I think it's important to make sure that you learn and see the whole concept.
That's good. These are really good, important pearls. Finally, final question. It's so impressive to go back to what you started with, the statement that you all have hit 500 thrombectomies a year, which I think is one of the highest in any center in the world. So congratulations. That's like super impressive. And I just want to understand and learn myself. There are many institutes across the world which have the wherewithal but the triaging systems, the administrative systems, logistics, all need to be probably have to learn from institutes like yours so as to grow this to this number. So, can you give us a few words on that? How did it grow to be so good?
Yes, I think first of all, there are a couple of reasons to it. I think one reason why because it is over many years, over many people with different roles and different situations. And I think one thing was that we got maybe a head start because the Karolinska said that, for instance, when the people were teams and centers were joining the Hermes trials, that Karolinska said we don't think it's ethical to randomize these patients, and I think the Hermes collaboration was super strong and made a really strong effort for this patient group. So this is, and I would say that it has to be hugely respected. But getting that head start into thrombectomy, we were able to push and with a close collaboration with stroke neurology and neurologists to develop the Stockholm triage system in parallel. So I think one important thing is this has taken time to grow, so over 10 years, and getting to the point of this volume is that all the centers around that emergency departments, physicians learn that, what is an LVO and how this can be treated. This is information that is continuously spreading in different ways. And I think I would be more than happy to I mean, give all back and share all information. And this is what we do. We share all the information on our protocols, and the Stockholm triage system is published in a lot of papers. It's called the A2B2 system is in paper. And so okay, we cheated and got a head start by not participating in the Hermes. So let's see, can we give something back? And in this way, I would. But yeah, it's. I think I don't know if that answers your question, but one important thing is
Yes, it is. It is because I mean, a part of it, of course, like it's a very complex question. It's got many layers to it. Information amongst the lay public, amongst doctors, amongst the ER, our own administration, getting our in-hospital systems catered to that. So it's a very complex question which doesn't have a single answer. It'll require many podcasts and many in-person visits. Like, I would love for you to visit us and move around the hospital, and so maybe someday we will do that. But as of now, it was absolutely fantastic to have you, Fabian, on board. We learned so much from your cases, your experience, your skill, and this very small thought of us that many of us are so busy in our day-to-day jobs, but while you're driving to work or we're just cooking up a meal, we can listen to a podcast. And many of us have done these procedures. We just need to visualize them, hearing it from experienced masters like yourself. So thank you again, Fabian, for being part of Getting Wired. And we hope to see you on board soon for the hemorrhagic segment as well.
Absolutely, my pleasure, Rajeev, and thank you for. It's an honor to be part of this, and great job doing this. I think it's a very important. Thank you.
Thank you. I hope to see you soon. Thanks again.
Yeah.
That's a wrap on today's episode. If you enjoyed this conversation, don't forget to like, comment, and share. And for more insightful discussions, make sure to subscribe the channel.